So we are on week 9. There are some pediatric assessment assignments still has not been turned in. You have till Sunday. I highly recommend, yes, it's 10% deduction, but it is 6% of your grade. And unless you're a high 90s, most likely it will have you fail the course if you don't hand it. So just keep that in mind and get in as much as you can. All right. Also, anybody who doesn't have 100, I've put in little notes where you can change it. I will give you the opportunity to reevaluate what I've said, resubmit, and I can regrade it for you so that you can get the best grade possible. Now, why do I do that? And Dr. Brown knows I do it. Well, many of you I know are going to be going on in your education, whether it's your BSN, MSN, and be crazy like me, a PhD, but many of you will go on because your hospitals require it, or you want to go onwards because you want management positions or nurse practitioner. So I want you to learn from this experience because BSN, MSN is all papers, it's all APA. It's all brochures, PowerPoints. That's what it's all about. And as you go forward, pick a subject that you are adamant about, that you love. The thing that I chose was all about needles and children and their fear of it. So my dissertation is school-age children's attitude and behavior towards injections because they have fear, stress, and before, during, and after. So I worked on a lot of different things with that. And I carried it through my BSN, MSN, and of course into my dissertation. So just think about that. So anybody who wants a better grade, not a problem. If you don't, I understand. You're very, very busy. But if you do resubmit, please let me know that you have so that I can regrade it for you. Okay. Sometimes it's hard to see if you don't let me know. I've got more than one class. I've got over 45 students. So I want to make sure that I give your project all the attention that it deserves. So week 9, you still can hand in your pediatric assignment exam if you haven't. You still can hand in NCLEX if you have not. Again, both of those are minus 10%. But this week is discussion question 6, and it is dosage calculation. I've already been asked, can you print it out, write it on a paper, send it in? And the answer is absolutely. Whatever works for you, okay? If you want to type it up, I think that's harder. But if you want to write it down, it's okay. Just send in the pages and I'll grade it from there. So thank you earlier for the question from one of you students. So next week is going to be exam 3. I've already done my review. It's already posted. We have more reviews coming up. We know that today there was one earlier. I don't have that up yet. That's from Professor Pace Chismar. Honestly, she teaches very much like me. I mentored her. I was her first person that taught her how to teach because it's her first teaching job, but she's been here a year now. So she's doing a great job if you like that. Then we have tomorrow, we have Dr. Goet, Professor Luminoso. And then on Friday, we have Professor Morris. Usually she did the Saturday classes, reviews, but she's doing a Friday. I guess she's giving herself a weekend. And for her, well deserved because she even does reviews on Sundays with her class. So, she deserves it. Now, anybody who wants a one-to-one, I've already been reached out by a couple of you to go over some concepts you're not getting. Next week, I will do. Now, I'm not going to do a whole review with you, but I can do, I don't understand this. I don't understand that. Bring questions, or I'll start, putting questions out to you. Do you understand this and that? Okay. I don't think the exam is crazy. I don't think it's these bizarre questions. I think they're straight out and forward. And I think all of you in your PowerPoints and in your Kahoots are totally prepared for it. Okay. So let's go on into what we're doing today. Let's go into PowerPoint. Anybody have any questions?
Can I ask one quick question in regards to the quiz?
Absolutely.
The question that had to do with the acute renal failure, was it the hypertension,
It is oliguria.
oliguria, and hypertension then? So
Yes,
it was
because
that one.
remember, in acute renal failure, what happens? Something happened that stopped your kidneys from working. So oliguric means you're not urinating. And then, of course, with any renal stuff, it is hypertension. So yes, yes, it
Okay.
is Genesis.
All right, thank you.
I don't always mind giving one question out. It's like,
Thank you.
so this week we're doing chapters 48, 49, musculoskeletal, neuromuscular. And I'm going to go over those concepts that you're going to see, whether you're going to see these things on your HESI, whether you're going to see it on an NCLEX or exam, right? I hopefully have covered all of them well enough that you're not going to be surprised. So let's talk about children. We talk about musculoskeletal, where, these children can't move for whatever reason. Congenital defects, about osteogenesis imperfecta. This is what we call brittle bone disease. I mean, you can't pick these children up, and you have to be so careful because just touching them sometimes bones will break. We know that sometimes kids are sick, prolonged therapies, and they're in bed. And with that, they're going to have those foot drops and they're going to have maybe possible sores, bed sores. And you think that's only adults. It is not, it's children also. The muscles get weak, the bones get more demineralized. And then, of course, respiratory, cardiac. You're starting with venous stasis and edema and fluid into the lungs. All of these things are part of what the body sees. Now, the child, you have a kid who is on, immobilized. They can't move around. They have to be stuck in a bed for whatever reason. Remember, they are in that little reduced little environment. So they start feeling frustrated and helpless. And many of the times you'll see them start getting angry and a little aggressive. Or you're going to see them regress. Children at that 4 or 5 age are going to start to suck their thumb again or need a diaper, being incontinent. It's all normal stuff. Now, what the family? Not only is it mom and dad, it's also brothers and sisters, aunts and uncles, and grandmas and grandpas, isn't it? So, a lot of times we as nurses have to remember the family in there. Sometimes it's a nurse just asking, so how is grandma doing? How is, his brother doing, his sister doing? And the thing about many hospitals that work pediatrics, and I know where I came from, they had what we call these parent groups. Every floor had a specialty, whether it's cardiac, whether it's neuro, whether it's respiratory. And they had family groups of these chronic children, and they'd get together, and it was once a month, and they really talked with each other and they helped each other. Some parent would find how to do something, another one couldn't, and it was really great to see. Now let's get more into, muscular skeletal. What happens? Well, how many of you have, sprains and strains and, just because, you didn't exercise and decide, oh, tomorrow I'm going to start exercising, right? And then you go to the gym and all of a sudden the next day you feel horrible, right? It's just part of, doing, too much too quick. So it could be that, injuries to either muscles, ligaments, or tendons. Now, children love to fall down, bump into things, and contusions in itself, bruising is not a bad thing. But remember, sometimes bruising goes deep into the tissue, depending on where it is. It could have been that crush injury, right? So always remember with contusions, their swelling could be a compression of a blood vessel. Neurovascular signs are always number one when you look at stuff like that, especially with extremities, fingers, toes, those things. Are we still moving them? Are they still good color? It's a good thing to look at. Now, dislocation. One of the most common ones that I see with dislocation is what we call a nursemaid elbow. Have you ever seen a child 2 to 3 years old? And we like to swing them around by their hands, right? And it's really, they love doing it. But sometimes their elbows, the joints pop out, and now the joint is not in good position. It's out of joint, and the arm is hanging down, and they come in because it hurts and they can't move it. And all we have to do is click, click, and we put it back in. It's because those tendons are so soft, all right? And we put them in just an arm sling for a day or so, just to rest it and say, yeah, you can't do that anymore because it is those tendons. So they stretch so easily. What about your Downs children? Have you ever watched them? They could take their legs, put them behind their head, both of them. They are so flexible. One of the things we have to be careful about is hip dislocation. They don't know better, remember? They're cognitively delayed. So they're not going to say, well, if I put both of my feet behind my head, I could do it easily. It doesn't hurt. But poof, out comes the hip joints. Remember, that could lead into loss of blood supply and cause problems with hips and all of that later on. Now, I think all of us have had a sprain for some reason or another. I think one of the things that, me growing up through high school and college, I was the jock. I had 6 brothers, so I was the woman, the girl in the family, and I followed in the footsteps. I was second to youngest. And I would especially volleyball was my Waterloo. You go up, you spike a ball, you come down and you crunch your ankle, and now you've got this sprain. I think sprains are harder to treat than absolute breaks because it's not a broken bone. It's just a stretching, and the swelling is intense, right? So that's a sprain. So rice, we're gonna rest it, ice it, contain it with an ace bandage, and elevate. We'll go into that a little bit more. And then strains. I think today, especially when you get to adolescence, they are trying so hard to get these sports scholarships, or now we're into Olympic world, right? Where these children, young adults, are doing the same thing repeatedly, and now they're going to get these little microscopic tears. And it's that strain that can occur. So, how do we treat get a sprain? I know that when I went up, spiked the ball, came down, I was on my ankle. I've done it more than once, as you can tell. My leg would go right up in the air to elevate it right away because I could feel it already swelling. And getting ice on it, constrict the blood vessel so it doesn't swell that much. Put the ace bandage on it to prevent it and get it in the air, right? Today more than ever, and this is a change in practice from I first started nursing, they're putting casts now on a sprain because some sprains are actually worse than breaks. So they put casts on them to keep it immobilized so that it can heal properly. Now, one of the things that children do is when they fall, they put their hands out, don't they? And how many bilateral forearm fractures have I seen? Do you remember when the hoverboards came out several years ago? That Christmas, I had two 10, 12-year-old boys come in, bilateral fractured tibia and fibulas, radia and ulnars, right? Both their wrists were fractured, and they got cast on both of them. It is common. Put your hands out. It's what happened. Now, if we have a fracture in an infant, there's a problem because their bones are softer. They heal very quick. There's something that shouldn't be. So if we see anything in the infant, it's probably requires some investigation. And I've seen young infants at 3 months old that actually were abused. So again, as nurses, we're there and we are our advocates for our children, making sure that children are safe and not put back in the homes where abuse is happening. So there's all sorts of fractures. The most common, that's simple, that clothes fall down, the skin's intact, and there's a break underneath, whether it's a crack, a full crack, maybe it's dislocated, but this is just, it doesn't break the skin. Put a cast on it, get the bone straight, and we're gonna, do it that way. Now, an open or compound means the bone came through. As soon as the bone comes through the skin, what is our concern? Infection. Infection in osteomyelitis requires a minimum of starting IV antibiotics. Will they be sent home? Usually they go up to the OR with these open wounds. They want to clean it out. They want to fix the fracture. They want to put a cast on it. And to manipulate the way they should, they do it in the OR. But IV antibiotics, and again, monitor for osteomyelitis. Complicated, this would be like a rib fracture. It goes through a lung, and now you have a pneumothorax. That's a very good relationship of complicated. Comminuted is when the small fragments of bones are like all over, so it shatters a piece of that bone in there. They hurt. And then, of course, avulsion is when the bone pulls away from the tendon and ligament, and again, it needs to be casted. Now, children are growing, right? That's our big thing and our difference between adults and children. And they grow in the bones in a place called the growth plate or the epiphyseal plate. It's like close to right to where the bones meet each other, whether it's in the elbow, knee, wherever. And it does grow from there. But many kids, for instance, I think the monkey bars, when they fall down on their elbows and they fracture right at the epiphyseal plate. The problem with these fractures is if we don't fix them, put an open reduction internal fixation surgery, get them really lined up, you might have a crooked or a shorter leg or arm. And we don't want that, right? So that's why they require surgery. Now look how quick children heal. Infants, very quick. One of the things that in children that we get is those club feet. And their feet are just like crooked, they're not the way that they should be. And we can do serial castings and every week change them. And by a month, we can get almost those feet where they should be. Later on, it's 4 weeks. Me and you is 8 to 12 weeks or more for our bones to heal the way that they should. So we get a kid in complaining of fell down, my wrist hurts. It's swollen, it's tender, it's painful. So we do an x-ray. Now, one thing that we need to remember, fractures, yes, they're usually accidental, but many times it could be due to a parent doing something, or the spiral fracture where they twist the arm and it crunches like to the side. That's usually child abuse. So always be suspicious of these sort of fractures, okay? And again, always taking your child and putting them your first priority, keeping them safe. Now, there are children that come in that tried to put the pressure on their leg. Maybe it's a, tibia, a fibula fracture or something going on there. When they don't put their foot on it and they don't put any weight, you can almost be guaranteed it's going to be a fracture. So our goal is to prevent deformity. That's always number one. And keep the function, restore it where it should be, and keep it, reduced where it needs to be, immobilized, so that we can have, that joint be what it needs to be. Now, sending a child home with a cast. Now, we need to teach them. Just because they have a cast on, it's not the end of it. Sometimes there's so much swelling going on underneath that it can cause death of tissue. Now, yes, the picture on the right is the most bizarre, the most extreme, but I just want you to know that that can happen. There are parents that don't get their kids in quick enough, can't, or they're abused or something. They can lose their whole arm. if we're not making sure that the cast isn't too tight, including circulation, right? So 6 P's. When they're sent home, if the pain is increasing to the point it's getting worse, the fingers are getting pale, that means there's no circulation. If you can feel for a pulse, you can't feel it, or it's so minimal, or now the fingers are getting numb, and then that big pressure in there. These children are told to return back. Most casts today are put in an emergency room or in urgent care. So go back, let them check it. They can always change the cast. Now, casting in children, we've got to do something so they don't feel so threatened. So look at this little girl. It looks like she had some sort of hip something going on there, but her doll got cast too, right? So now we have made it less threatening. Also, there's colors. I've done what we call conscious sedation on children on really bad fractures, and we say, so what colors do you like? Well, it could be the football colors, the basketball colors, Christmas colors. It's like when they wake up, they see that red and green, or they see that black and red for Miami Heat or whatever. And now it's okay. It's not as threatening as it should be. When they get home, we need to teach them how to take care of it. I think the biggest thing is not to get it wet. I live in South Florida, right? How many children, and it's too numerous really to count, that get a cast on, go home, put on their bathing suits, and jump in the pool and go, oops, I didn't know I couldn't get it wet. Now their cast is wet, and now they're at chance for all sorts of infections underneath that cast. So it does need to be changed. I saw one kid do it 2 times. I thought his mother was going to bop him one, but she was patient with him because, again, you got to go through that whole ER process. One of the biggest complaints in fractures is the itching that goes on. So nothing underneath the cast, right? But a cool hair dryer is probably the best thing we can do. But not to stick anything in there, no lotions, no powders. A cool air dryer, that little bit of breeze actually helps. Now, there are times, especially with a fractured femur, where we need to pull those bones apart and get them, approximated. Fractured femurs, you have a big thigh muscle, right? And when it fractures, it pulls it. So now you've got these really sharp edges going into muscles and nerves, and it hurts. So this traction pulls it and puts it back where it needs to go. We do that a lot, usually with a skin traction. There are other ways where we do skeletal traction. But when we talk about traction, whether it is that skeletal, like the cervical traction on the left, even on the right, that looks like they had surgery on their neck there. But if we have that traction, and put those bones where it should be, the muscles and the spasms are going to decrease. What does that do? Now, we used to put in stymon pins and then let them heal for a month before we took it out and then physical therapy. Today we're putting rods down the femur instead of doing that. So traction actually gives them the chance to get to the OR, to get that rod put in, and to have a little bit of time where it's not such spasming, muscular, terrible pain. Okay. What is our job, with these tractions? Well, upper extremity traction is very uncommon. We don't really use anything in the arms. It's usually for the legs or for the hips. You know, yes, we do have some for the neck. Bryant traction is that bottom right one. And that's a little child who's had hip dysplasia, and the simple things and Havlik harness, and we'll go into that in a little bit, don't work. So they put it in these Bryant traction and hold them up and possibly get that hip joint back in so they don't need surgery. As I said, fractured femurs. What type of traction do we use? It's a skin traction. We put like this little Velcro boot on, and it has on the end a little area where it connects to a string and a weight and a pulley. And it pulls that leg to keep that bone approximated. Now, never, ever, ever take it off and keep those weights hanging freely because it needs to pull. You release that weight, those bones are going to slip, and now you're back into all that severe muscle pain, right? Cervical traction, Gardner-Wells tons. These are fractured necks, and they're skeletal. They'll go into the neck, approximate it until they can get to surgery and do a repair. Another thing we can do is what we call distraction type thing. Sometimes this is due to a child that's born very short. Maybe one leg is shorter than the other, and they want to equal it out so they don't have to wear orthotic shoes, right? So they'll take these external fixation devices and they'll break the bone and they'll support it, and then the bone is going to heal. Now you're going to have equal length legs or arms or whatever it is. What is our job with an external device? Well, there's a lot of points where metal goes into the bone. So it's pin care, watching for infection, neuromuscular signs. Now, children can be born without bones. I had a friend whose daughter was born without a fibula in her lower leg. So there's no way to replace it. So they had to do a below the knee amputation. That girl didn't even know that she was different. She actually, the first time that she met my children, took off her prosthesis, was going up and down the stairs and trying to bop my kids over the head with her prosthesis. And she was quick on her feet like you can't even imagine. So it's how you treat the kids, right? There are times, crush injuries, etc., where sometimes you have to, all of a sudden remove part of the leg. Remember, any amputation, adult children, it's always going to be that phantom pain, right? Always is there. And our goal is to get that, whatever extremity that we can have a prosthesis so they can actually walk and be normal like kids.
I have a
Now,
question.
sure.
So, for a kid like you said that had was born without the bone and then had it like right as like a newborn, would
Mhm.
they still have phantom pain?
Oh, absolutely. Why not? Absolutely. And it's something to be looking for, whether they're newborn, 1 month, or, 10 years old. It's still that nerve that's left there. And, you know, it's something that needs to be addressed. So, yes, thank you. Very good question. So, sports and children, they're so competitive, aren't they? They love to win. And especially boys, they love that rough contact and all the things that go with it. Remember, with any sports, there's always going to be injury. And your discussion questions talking about children and sports, very important that we allow them to do it, but make sure they have the proper equipment and that they're not going to overdo those repetitive things that creates those strains, etc. And then be there for that emotional part of it. Overuse, I've already sort of mentioned it. Remember, this is like your strains where you do the same thing over and over again. Now, DDH, developmental dysplasia of the hip. When you walk into the pediatrician office with your brand new baby, what is one of the first thing that they do? They take their little legs, move them back and forth and up and down, and they're listening for a click, and they're looking to see if one leg is shorter than the other. They turn them over and they look at the gluteal folds. Are they equal or different? And if they're different and they're clicking, guess what? You have a DDH, a hip dysplasia. As you said, one limb will be shorter. You're going to have that restricted abduction where the side, You just can't get that leg where it should be, that positive Orlani and the clicking and the positive Barlow. Now, how do we treat this in children? Remember, it's 2 to 3 weeks, bones heal. So we put them in something called a Pavlik harness, and it abducts the hip, puts it up where it needs to be. They wear this 23 hours a day. They'll put a cotton t-shirt underneath because they're moving, and it's going to be some sort of movement of this harness. So we're going to really be careful of skin irritation underneath it. And we only take it off to bathe them, change the shirt, and put it back on again. Sometimes they have to go further and it doesn't work. It's not that frequent, but it happens. This is the child who's that 8, 10-month-old in a spica cast, right? Where they have the bar between, you have to carry them around. And then if it still, for whatever reason, hasn't, reduced the way it should, you have to go in there and cut the tendons to be able to get it where it needs to be, and then cast them. And that's when they're older. I mentioned club feet. Now, you don't have to know all the names of the types of club feet, okay? What it is the club feet are in, out, up, down, around. They're just not the way they should be. That's what you need to know, what a club foot is. How do we treat club foot? Well, as soon as we see it, what we're going to do is to correct the deformity. It's called the Ponseti method. And you can see all the casts. Once a week, they come in and change it. Because remember, they heal quick, right? 2 to 3 weeks. So we want them to come in quick, and we'll keep getting that where they should be and get those club feet corrected. Now, this child is going to need further up follow-up by some sort of podiatrist, making sure their feet are right the way they should. Maybe they need special shoes, but we can take care of club foot really, really quick. 1, 2, 3, 4, 5, 6 weeks. Look at that, because it's changed every week. I mentioned osteogenesis and perfecta. I've seen one in my career, and this little boy, when you went to try to pick him up, you were so afraid if your hands went in, you'd crunch a hip or a rib. So we would always pick him up with a blanket. I'd always have 2 people picking up and moving them. And it's nothing you can do. Their bones are brittle. Yes, we can give biphosphate therapy, this, that, and the other thing. But our goal with these children is to keep them in some sort of positional way where they can be mobile. These are the children where I used to see in my hospital that would be in these motorized wheelchairs. And you'd be going for lunch and you'd hear beep, beep. And these young kids in their motorized wheelchairs be going into the cafeteria to get food for themselves. And you knew, because, when you work in a pediatric hospital, you sort of get to know your kids. You know that one of them was in osteogenesis imperfecta. We tried to keep them as mobile as possible. Now, late calf birth disease is an ischemic aseptic necrosis. So the head of the femur doesn't get blood, but it doesn't have an infection, and it starts to erode. So the head of the femur is gone. So all of a sudden, these children, you would start to see them limp, and they can't really move the leg the way that they should. And then you do the x-ray and you see something's going on with the head of that femur, that ball there, right? So our goal is to decrease that inflammation, to rest it, and sometimes they'll even put them on Buck's traction at home. And again, now we have a child with a bone condition who is at home, so nutrition's important. I mean, think about bones. What do we need? We need good vitamin D. We need calcium. We need protein for healing. High in those things would be what we want. And NSAIDs. They don't need anything more than that. It's an anti-inflammatory. Now we're going to go into spinal conditions. Kyphosis is basically a humpback. It's the upper spine gets curved in. When we think of kyphosis, we think of the old lady who's bent over, right? And look at that, they have the humpback. Lordosis, you don't see as much, but it's the low back is curved in. So they sort of angulate backwards, okay? And then the one thing that you need to know about is scoliosis. This is an S-shaped curvature of the spine. It happens usually at that pre-adolescent growth spurt that we really see it. We're going to see a shoulder low, and we're going to see the curvature coming on. And, you know, there is some school screening, you know, that's always been controversial, the health office, blah, blah, blah. But, if they're seeing a curvature, what do we need to do? Well, they're growing 20 to 25% and their pre-adolescent growth spurt. And during that time, we need to strengthen the back and put them on a brace so that they can be as straight up as they can. Now, as long as it is less than 40, 45 at the most degrees, we can do bracing and we can do exercise 23 hours a day. Again, another nice cotton t-shirt underneath, no creams, no lotions, and they only take it off to shower and put it back on. Now, if the curve is really curved, it's now impeding in the lungs. So now you are, taking space from breathing. So what they'll do is surgery, trying to straighten it out, because just the exercise and a brace is not going to give you everything you need. So this is the Harrington or the Lukey rods or spinal fusion. There's all different things they're using right now. And after surgery, when you get the rod put in, this is the one that we're going to do that log rolling. We've heard of it, right? This keeps the spine straight, pillow between the legs, and you turn them in one continuous motion because they'll be on bed rest for a while after that surgery. Now, we mentioned osteomyelitis with open fractures. It could be, actually, what I've seen a lot is children outside bare feet and their big toe got something in it. And now it's red and swollen and it is an osteo. So what do we see? Well, initially it'll hurt and then it will get red and then it will get swollen. Maybe not. It'll have, some pus or something drained from it, but then it goes systemic. And then all of a sudden you're going to start seeing all the fevers and the chills. Leukocytosis, elevated white count. It is an infection. So we'll go in, we'll take an x-ray, we'll see some fuzzy stuff on it, basically is all we see. And then we need to do treatment. Osteomyelitis, we always concern, this is usually a staph infection. It's the outside coming in. So think about staph and the type of antibiotics intravenously we use. Isn't that your vancomycin? Isn't that your aminoglucoside? Aren't these the ones that are highly toxic to your kidneys? So again, with these sort of things, we need to monitor their blood levels. They're making sure their white counts are coming down. Their kidney and their livers are responding to it, and they're not failing for you. It hurts. Again, bed rest, make sure that pain is taken care of. And again, you are with a bone infection. It's high protein on these children. And because it's a long term, usually a month or more on these children, they're home many of the times getting these IV treatments at home. So again, those psychosocial needs are a lot. Ewing sarcoma is another type of bone tumor. Now, we mentioned the osteosarcoma in the femur, right? Well, this is like in the shoulder blades. Could be also, in the tibia, the ulnar, the humerus. And it's a big that attacks the bone. And it's usually in your adolescence. And again, sometimes they need to do chemo, radiation, sometimes surgery, and sometimes remove it. Hopefully, by the time we see it, that they have had no metastasis, because that's our best thing. Now, JIA, or rheumatoid arthritis, is the body attacking joints. So the joints are inflamed and they're painful, especially when you've sat for a long time or in the morning. It can be triggered by stress, environment, many things can make it worse. I've seen the kids young, ages 1 to 3, that we see them with JIA. And it's because all of a sudden we see them limping. It's probably, and I'm telling you, I have rheumatoid arthritis. Took 8 years for me to be diagnosed. 8 years of figuring out and them telling me all sorts of crazy things. And then finally, I get my diagnosis and I'm off the chart on all the lab values that they have. Now, with JIA, as I said, the joints are swollen, inflamed. So in the morning, you've laid there and haven't moved. So to move those joints, you are stiff and it hurts. Therefore, you have difficulty walking and you might be like rocking side to side. You might have a limp. Again, there's joint swelling. We've seen with JIA or even rheumatoid arthritis, fingers and hands that go all over the place, right? The one thing that we don't talk about with JIA a lot is uveitis. It's, the iris gets inflamed and you see a red eye. That's why they should go to the eye doctor once a year. Now, the problem with JIA is there's really no definitive test. We can look at all the inflammatory factors. We can look at SED rate. We can look at C-reactive proteins. There's an ANA. There is a rheumatoid factors. As in with me, like I'm telling you, I'm positive, negative, positive, negative. And it was hard to determine. There's a couple more tests right now, which finally diagnosed it. But it is a frustrating thing for parents and for children. And when you are flaring, you will see your white cells go crazy with the leukocytosis. So our goal with JIA is keep you moving, keep the function, prevent deformities, and try to keep your pain as minimum. NSAIDs are the best pain management here. And then, of course, something to stop the immune system for attacking the joints. And those are your anti-rheumatic drugs. Humira, we've heard of, Enbrel. And then there's all sorts of infusions out there. So there's many choices. What I have learned is just like antibiotics. Some of them treat certain things, and there's different grouping of antibiotics. Well, there's different groupings of drugs used for JIA, which is, different brands. So they can change and change and change. Also, of course, steroids are the one that we use for that very much when you're in a lot of pain. We'll give corticosteroids. And methotrexate is almost for all of them. Something that helps is a chemotherapy unit. And again, it is there to help you. So, goal. I mean, I swim as much as possible. That is the way that I keep my body moving. A child, if they like to run, they like to play sports, whatever it is, let them go. It's what we should encourage. It helps them keep the muscles and the joints moving. We know that taking NSAIDs can help. We know that heat is good and exercise. I hate heat. Some children like cold, just like me. And again, it's all personal, what helps. Now we talk JIA, body's immune system attacks joints. Well, what about lupus? Systemic lupus attacks all your body organs. All right, heart, brain, liver, skin, kidneys, doesn't matter. It will attack. There's no preference in it. It is with more common in girls and women that 10 to 19, African American, Asian, Hispanic. And we know probably this is where they're going through puberty, all that hormonal imbalance going on, right? It could be due to infections and stress and stuff, but also overexposure to sunlight. I live in South Florida, so one of those is something that I need to pay attention to, right? That cutaneous rash. I put one that looks a little bit different than you would think. Like that girl, that's a butterfly rash, or it could be just red there. They can look like a lot of different things. They start nausea, vomiting, diarrhea, and pain. When they start getting diagnosis is when they start getting weak and the stiffness going on. And now sometimes it gets to the point of seizures or that paralysis. And then they figure out, oh, something's going on. Let me go get treated. And again, pleurisy, lungs, pericarditis, that's your heart, proteinuria, renal failure, that's your kidneys. Now we know the lupus, where it's attacking. So our goal is always supportive. With this, they give a lot of steroids for these children. And again, with these children, we have to be really careful with sunlight and sunscreen, because that's one of the big things that can cause, them to have these lupus attacks. So Kristen, 10-year-old, had a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? What is the epiphyseal plate?
Growth plate.
Yes, it is. And we treat it with surgery, open reduction, internal fixation, because we want that bone straight so that they grow straight and it will be equal to the other arm or the other leg. Yes. Now, neuromuscular, musculoskeletal dysfunction, when we think of that, number one is cerebral palsy. And this is that it's a permanent disorder, nothing that you can change. It's abnormal muscle tone and coordination. And many of these children do have epilepsy. Why does it happen? Well, sometimes it's the brain, it wasn't formed right, or vascular occlusion, which means an hypoxic episode. Low birth weight, young premature infants are more at risk. I've seen it happen a lot where at birth, let's say they tried to do vaginal delivery, they couldn't, they had to rush to the C-section, pull them out, but they had a hypoxic episode, and then you see some level of cerebral palsy, and that's that hypoxic infarction, and there's that interventricular hemorrhages. Their brains are so fragile as those young premature infants. So when we talk cerebral palsy, there's all different levels of it. Now, the one that we think of is that spastic one, the one that, I have where I used to work, do clinicals for Fortis here on ground in South Florida, is this place where I had this little boy named Jonathan, and he was 7 years old at the time, and nonverbal. In fact, he's fed by a G tube. The kid was smarter than you could ever imagine, and me and him bonded. And when he saw me, his arms would go up and he'd get so spaz, it gets so tense, and he'd get this big smile. It's that hypertonicity. And this child couldn't walk. He was in a wheelchair. He had to be, strapped in with, shoulder harnesses because of that poor posture, and this child was alert inside this body that could not express. He had a pad where the Marchadines gave it to him, where he could talk to us. So it was quite amazing to see this 7-year-old child, nonverbal, very spastic, but could talk, through this pad. So cerebral palsy is absolute delayed gross and fine motor development. All of it, all of it's there. Their muscle tone isn't the way they should. They don't sit. They're just sit crooked, abnormal postures, and some of these children we can get up and walking with splints, etc., but some not. Now, our goal with cerebral palsy is many of them are alert in their brain, right? So give them the way to move, to communicate. Like this boy here on a wheel on this bicycle, he's got splints on, but he's able to move around. And that's what you need to do. Give them the opportunity to move around, go and get things that they want. Makes them feel important, right? And then with Jonathan, my kid, he had that pad, that communication, and that does help that he could talk to us. And with cerebral palsy, now, I used to work with these children in high school. And I'm telling you the difference between when I was 17 and today, and I'm not telling you my age, it's too old, but it's amazing. Years ago, we'd get them out of bed, put them in a chair, make sure they were safe. We would help feed them, put them in front of a TV, and that was what we did. You know what we do with these children today? Occupational therapy, physical therapy, speech therapy. Jonathan at age 7 with severe spastic cerebral palsy was doing his shapes, was doing his colors, was doing his numbers, things we never thought they could do. And our goal is let them be the best they can be, and then let them be more than what you ever expect. Just keep them, progressing. As I said, ankle foot braces to hold them so they're not so spastic, and surgeries to release those spasticity deformities. We do use things like botulism, that helps decrease the muscle from tightening up, right? And then dental hygiene. Most of them have epilepsy. Remember, they're unphonoidin, dilantin, gingival hyperplasia. So we got to make sure that we take care of their mouths. And again, keeping their muscles open, physical occupational therapy really helps. So cerebral palsy, 85% can get up and move. There are that few that can't, like my Jonathan, but, thank goodness he's alert in his own way. These children turn into adults, right? And the families have to take care of them at home. So making sure families have everything they need, how to take care of them, how to keep them safe. And then, of course, having them in a program of physical, speech, occupational therapy so they can be as much as they can. Now, something happens at birth. Now, we had the omphalocele. We've had, your bladder exstrophy, where things are born on the outside of your abdomen, right? Well, it can happen in the back too. In the lumbar spine, sometimes we have the meninges and spinal cord. What happens? It pulls up from the lower extremity and pulls out. So if it pulls up from the lower extremity, those lower extremities are going to have decreased movement, feeling, if any. Okay. And usually when we talk neurotube deficits, we're talking about the myelomeningocele. And it has to do with fluid going up and down the spinal cord too. So it's a lot of things. It probably is due to mom, obesity, diabetes, but the neurotube deficit, didn't you hear that in pharmacology? That's why we're going to take folic acid, right? To prevent these neurotube deficits. Well, so what is our goal? What do we need to do? So this child comes to you, you admit the kid to your unit, they have a myelomeningocele. Your priority is to take that big meningeal sac and spinal cord and put a nice sterile normal saline dressing on it and to keep it intact. And then as soon as they can, they're going to go put it back in But these children, we need to prevent from infection, right? Now, because it's ripped the nerves up, the bladder and the bowel control are questionable. Can they by themselves? So you have to make sure you're an output and your bowels are moving with these children. Also, what we've done with these kids is we've made them latex allergy from the moment they're born because a repeated touching of this open areas with latex has formed allergies. So today, we don't even use latex in the pediatric population. We don't. There's all different sort of drugs, type of, not drugs, but gloves to be able to be used. In fact, I ended up working in a premature nursery for a couple of years. I ended up with latex allergy with my hands. So when I moved to this hospital and there wasn't latex gloves, I was like, yes. And that's why I stayed there for 25 years. As I said, it's the folic acid that we use. Now, Wernicke-Hoffman is a spinal muscular atrophy. This is also called floppy infant. And the problem with this one is they usually die before they're 2. It's just they don't lift their heads, they don't turn over, they don't do anything, and as I said, they die by 2. Now, Duchenne muscular dystrophy is your most tested of all your muscular dystrophies. I've seen it on HESI, I've seen it on NCLEX. What is Duchenne muscular dystrophy? Well, it is a X-linked inherited. So mom gives it to the males that she borns. Okay. So males ages 3 to 7. Now, they're always cognitively delayed. That's part of the beginning of it. And they will, at 1 or so, get up, try to walk, and then they have these hypertrophic calves and arms. And then all of a sudden, they start waddling and getting weak because it's muscular dystrophy, right? Their muscles start to stop working. So it's that wasting that occurs. Now, these children, all of a sudden, they're falling down, they're just not doing what they should do, and they get treated. Now, it's a muscle problem. So we need to look at the muscles and seeing how they're working. So we do something called an electromyography. Now, many, many years ago, back in the 80s, I had a neck issue and they did an EMG on me. I mean, back early 80s, I think it was. And they just put those little tabs on me. They didn't even put needles because they can do needles too. And this little machine will give you an electrical shock. And what they're looking for is how the muscles respond to it. Now, once they test the muscles, they've worked these muscles out. It's like they've been at the gym. So these children will hurt after this procedure. So making sure that we have Tylenol or ibuprofen, something for them when they come back, and to warn them they're, working muscles, so they might have some hurting. Now, Duchenne muscular dystrophy, as I said, their muscles are getting weak, they're waddling, they're falling. Gower sign is something I do all the time. You sit on the floor, you get up, and you walk up your thighs to stand up, right? It helps you get up easier. That is part of Duchenne. Also, that lordosis, that inward curvature of the lumbar spine. So these children are progressively getting weaker and weaker. They need, and they tend to be a little overweight because they can't move their muscles that well. As I said, there is mild to moderate cognitive delays. So our goal is to keep as much function as we can, and to do genetic counseling for the family. What happens usually as an adolescent, they do their heart or their diaphragm, their muscles fail, and they die as adolescents. So that's when we talk about Duchenne muscular dystrophy. So outcomes are not great, after all of this care and treatment. Now, Guillain-Barré, this, I'm sure, I think you've seen it in MedSurge 2, or you're just about to see it. It is an infectious polyneuritis. It doesn't affect children that much, but it does. And it's something that you're going to see a child who's had an upper respiratory, something viral that's happened. And all of a sudden, it starts with the feet getting weak and the shuffling, the weakness falling. And then it goes up to the knees, up to the bladder. Then you might see incontinence, constipation, and the nerves stop working. Now, when it becomes a problem, you have a phrenic nerve, don't you? It attacks it and it stops it from working, so they don't breathe. So, how do we treat this? Now, I actually had an older, she was 20 some odd at the time. She was actually a nursing supervisor where I worked, and I was a supervisor with her. She ended up with Guillain-Barré, and she ended up in our intensive care unit getting all the treatment. So I remember it well. She couldn't breathe. They had to put a tracheostomy in her after 2 weeks, no more endotracheal tube. And they had to wait for all of a sudden it went from, oh, I can breathe a little bit. I can feel, urinating now, and now I can move my legs. So starts from the feet and ascends upwards. And then as they get better, maybe steroids, they're not sure. IVIG, supporting them, respirators, making sure all the complications that we're preventing them, and then it goes back down. It's interesting that with ventilators, when we have a child or whoever, adult, who's not breathing, it'll just have whatever rate the machine is programmed for, 12, 14, 15, whatever it is. And then all of a sudden, you'll see this person start taking a breath. And then it's going to go back down the other way. Now, tetanus. Step on a rusty nail, right? Well, tetanus is dangerous. How often do we give tetanus shots today? Well, it's every 10 years. I have seen it go from 3 years to 5 years to 10 years now. And they also give diphtheria with it today. They found out that is what we do need. But tetanus is muscle rigidity right here in the neck, and you can't move and you can't breathe. It is progressive stiffness, swelling, swallowing is all up here. So we are maintaining airway. They're alert. And these children will be getting tetanus toxoid, vaccines, and just monitoring them. These children are sick, very, very sick. And they say if you make it beyond 4 days, you usually will make it. Because again, there's no airway. It's all tense. They're not, making any motion to move air. So we clean the wound, soap and water, put a nice antibiotic ointment on it. That's what we should do. And if we have any incidents of stepping on that dirty nail, making sure that we get a booster, an antitoxin, to make sure that we don't get tetanus. As I said, it's ICU. Remember, it's muscles tense. We're going to be on muscle relaxants, and they're going to be on a ventilator. And all of a sudden, 4 years later, it's fine. Now, botulism. One of the things they say with botulism is honey. Now, how many of you have been told by grandma that when your infant under the age of 1 is constipated, give them a little honey, and it will help them move their stool? It's cultural. I've heard it before. And the problem is was the honey pasteurized, sterilized? How long was it on the shelf before you got it? How long was it at home before you used it? Because you're worried about the food poisoning of botulism in honey. They say children should be minimum of 2 before we give any honey to them. What we see with botulism, again, it's a life-threatening respiratory paralysis again, okay? They'll start with vomiting and then problems with speech and swallowing and those things. Again, we're going to give the IV botulism. We're going to take care of the respiratory support, and we will wait till that paralysis stops. And of course, always nutrition.
Miss Bogart,
Yes,
does that also, so since that applies to honey, would that also apply to like Cara syrup?
yes, it does.
Because
Yes, it
like I
does.
remember actually giving that to my kids when they were babies because in my, at least in my, from my family, it was like my mom gave me that advice of like, oh, when
I
you were
know that.
little,
I know that.
yeah. Oh, that's so
Yes, no,
crazy.
I've heard it. It's not uncommon. You know, it shouldn't be done. And it's something now as you go forward, if you ever work in pediatrics, you can mention it. You don't give honey under the age of 2 because you don't know how pasteurized and clean it is. Does it have any like germs in it, like botulism? Thank you for saying that because it's true. I've seen it. Now, spinal cord injuries. Spinal cord injuries are motor vehicles, sports, birth. Remember, you're pulled by the head out the birth canal. You can disrupt the spinal column there. And then, of course, that in the car, hyperflexion, hyperextension, coup de coup, they call it, head back and forth. I've seen one really bad spinal cord injury, and it was a 16-year-old boy, and he had slid into third base. His head hit the defender's knee, and they heard a crack. Immediately, he was complaining of numbness down his right leg. He was airlifted to my hospital. I was the primary nurse on duty. Good looking, great kid. I had to sit with him, explain with him what was going on. And I had to, in the ER, which is very unusual, get him to the MRI because we needed such a clear picture of what was happening. He then, the left side, so right side is numb, left side is like not feeling too good. And he's scared. Okay. So I keep him calm, keep him whatever. Did the MRI, got him upstairs to the ICU. We put him on a cooling pad to keep the swelling down. Of course, sedation because on a cooling pad, it's cold. So we did do that. Now, he had surgery. That was on a Saturday, Sunday. On Monday, he went to OR and they fixed his neck. He had an angulated 5/6 fracture that literally was this shape and almost cracked his spinal column. He was close. Well, I went to see him 2 weeks later up in his room. He had some minimal weakness on the right leg, but it was all coming back. And he was going to some inpatient therapy place. And 1 year later, that boy came back to see me in the ER to give me a hug. He was perfect. No residual weakness. And that's why we do what we do. So, what is my goal? And how did I treat that child? And how did he get out of that ER, still with a chance to fight? It's because you keep that neck properly immobilized, and always I was at the head. I was making sure when we moved, I moved my count, not your count. So, what is that progressive infantile spinal dystrophy that causes floppy syndrome? It's your wording Hoffman's, isn't it? Anyway, any questions so far? All right, we do have a Kahoot. Have you noticed my picture's a little bit clearer today? I actually had to go buy a new computer. My computer fell apart and stopped working. So I'm working with a computer that I'm trying to still figure out. So here we go. So who wants to win today? Anybody else coming? Big boy Johnny. Okay. All right. On that note, we'll start. Thank you, John. Week 9, musculoskeletal neuromuscular dysfunction. You make me chuckle. So 44 questions today. What is the priority for a nurse to assess following a cast application? And what are we going to teach the family also, right? It's the 6 P's: pulses, pain, movement, sensation, all of the above. Very important, you know that concept. Don't forget it. A multi patient teaching for a child with a fractured bone that has had a new cast applied. So the hair dryer is good, no powder, no lotion. And we give them plastic bags, whether it's a short leg, long leg, short arm, long arm, and teach them if they're going to take a bath shower, cover it so we don't get it wet. We do not want it to be wet. What should the nurse monitor after a soft tissue injury? So you've got this big bruise. Was it a crush injury or they ran into something? Got this big bruise going on. I tell you, never assume it's this big because there's underneath that tissue, right? And neurovascular signs, always, always, always. When you're talking orthopedic, we're talking about ecchymotic areas, bruising, you want to know distally, is blood still getting there? A fracture that penetrates the skin is called. And that's compound. Simple, doesn't break, green stick. No, it's not, or buckle. Compounds, it goes through the skin. Our biggest concern, osteomyelitis. We need IV antibiotics for that. A multi. Bryant's traction. What is that? Remember, we start out with Pavlik harness. That don't work, we're gonna go further. So it's children less than 30 pounds because any more than that, we can't have enough weight there. It is for your dislocated hips, always with any traction, check for breakdown. And we have those hips like at a right angle, and it pulls it to try to get those hip balls, the femur balls, into the hip sockets. That's the second type that we use for DDH. What is priority nursing care of a child with a compound fracture? What does that mean? Compound. Compound means it's open. Our goal is to prevent infection and osteomyelitis. So it's IV antibiotics. What is priority nursing care for a child who fell off a second floor balcony? No, you're going to say, second floor balcony? Actually, I've seen 3 or 4 of them, believe it or not, in my career. All different ages, usually are younger ones. Toddlers will crawl up, get on top of the table, look over, and fall off. And it's, remember, our always concern falling off, we don't know, is make sure that neck is immobilized and that spine's immobilized. We don't want to cause a paralysis. And of course, we'll do neuro checks, but immobilization is number one. Principles of managing soft tissue injury include you have a sprain. What are you going to do? The soft tissue. Rest, ice, compress, elevate. That's RICE, right? Remember that. RICE. That and your 6 Ps. You'll see it again. Epiphyseal plate fractures in children may what? And it's right there after those joints that go together. It's right in here where you have those growth plates, right? So if we don't have them, where they need to be, we don't do the surgery, make sure they're lined up perfectly, you're going to have a crooked or a longer or shorter leg or arm, finger, toe, whatever it is. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? Why do we look for neurovascular signs, right? What are we worried about? So neurovascular, we're looking about blood flow. It's all about the pulse. Do we have capillary refill? Do we have the movement? Those 6 Ps, and then part of that is the pulse. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? You need to document what the weights are every shift so that it's consistent. Also, making sure those weights are freely hanging because you need that constant pull. You can never take it off. You don't take it off for AM care. You don't touch the weights. What you're going to do, keep them hanging freely and making sure you document how many pounds are there. What does it look like? It is free hanging. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? So everything when you talk bucks traction, you're usually talking about a hip dislocation. You're talking about fractured femur. Your neurovascular signs are your biggest deal with it. So capillary refill on extremities every 4 hours. What position do you put the legs in an infant with hip dysplasia? DDH. How does it go? Public harness. What does it force that hip to do? Abduction, adduction, internal rotation. It's ab, as in B, abduction. Very good. What statement by parents indicate more teaching regarding their 2-year-old infant with club foot? Remember, bones and infants, they're young, they heal quickly, 2 to 3 weeks. So, starting that treatment as soon as we can is number one. Number two, we need every week for them to come in. And as they grow, they're going to have follow up care, making sure it's growing correctly. Do they need foot prosthesis, shoes, whatever? To wait for a month is way too long. Remember, they heal in 2 to 3 weeks. A multi. Osteogenesis imperfecta. So it's brittle bones, it's the long bones that are crooked, and we're not going to do physical therapy on these children because you'll break the bones. One of the things, and I've seen documentaries on it, you see parents being accused of child abuse, and children are with osteogenesis imperfecta. Can you imagine going through worried about your child and now you're being accused of abuse? So it is one of those things that, again, sometimes it's nurses who figure it out. What is the pathologic cause of leg calf birth disease? You see that hip joint, how fuzzy it looks there? So leg calf birth is something happens, blood supply doesn't get there, and it's not an infection. It's aseptic. Very good. Kyphosis, what's that? Kyphosis is the upper back. It's the old lady who's bent over, right? That's a humpback. It's the cervical thoracic spine. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? DDH. They have it. What would you see? It's what the doctor on the first visit looks for, right? So it would be those leg folds. You're going to see those difference in the gluteal folds, the leg folds. Will be one on top of each other. One leg because the hip is up here, not here. One leg will be shorter than the other. And then, of course, we're going to hear all that clicking and stuff going on. Very good. Lordosis is described as, this is one of the signs of your Duchenne muscular dystrophy, right? So that is the lordosis is the low back. Scoliosis is, my daughter's best friend from an early age had scoliosis. And she did the bracing, and she did the therapy. And it's that S-shaped curve. Remember, if it's over 40, 45%, it's surgical intervention. Below that is physical therapy and a brace 23 hours a day. Adolescents with scoliosis have up to a 45% curvature of the spine, would need to what? So that's they're going to have surgery after 45. That's really the highest level we'll see. But that's wear a brace 23 hours a day, something cotton underneath, protect the skin, and it's only for a shower, and it's with a physical therapy. A multi. Teaching for a child with scoliosis with less than 40 degrees of curvature. So you're going to wear it 23 hours a day, that cotton t-shirt, because of the sweat that can happen, physical therapy, and they don't want lotion underneath at all. I mean, on the Pavlik harness, on the younger kids, you might because you want to increase their circulation, but older children don't need that. A multi, a Pavlik harness. So Pavlik harness is for hip dysplasia, puts them in abduction, always check the skin, and again, massage those areas so that we don't have any breakdown on those children during the bath. What is osteomyelitis? Osteomyelitis is when a bone gets an infection, and we treat it usually 4 weeks or more. IV antibiotics. Remember, nutrition is part of it. And remember, monitoring, because it's usually staff monitoring renal and monitoring your liver function. Very important with that. Goals for juvenile idiopathic arthritis include our goal with JIA is the body's attacking the joints. We want to reduce the pain and the swelling as much as possible. A multi. What might you anticipate for a child diagnosed with JIA? The joints can be disfigured. You're going to have difficulty and stiffness with walking. And remember, it can affect the eyes. So remember, they do need at least annual checkups. Facial rash, it's lupus. Very good. What is cerebral palsy? So that's all about your muscles don't work the way that they should. So it affects body movement and muscle coordination. A multi. What are signs and symptoms of spastic cerebral palsy? Their movement is not where it should be, poor fine motor and gross motor skills, posture, that hypertonicity, and they have a hard time just balancing. Safety is a big thing with those children. A multi. When feeding a child with cerebral palsy, what's important to remember? Remember, cerebral palsy has to do with muscles and the specificity of muscles, whether it's chewing muscles, breathing muscles, or movement of muscles to be able to ambulate. So, what would you need to remember here? Keep the head of the bed elevated and give them time to be able to chew and swallow. Always having suction at bedside or in the area is good. And actually, thick liquids are better than thin. A myelomeningocele. And that's the hernia of the spinal cord and the meninges. When those nerves are stretched and pulled, you can imagine all of the damage of the lower extremities that might occur. So a multi. What can help a child with lupus erythematosus prevent its aspirations? It's a little bit of everything, isn't it? So wearing sunscreen, decrease exposure to sunlight, absolutely that can cause it. But also, if we're going in for any sort of dental or any procedure, always prophylactic. Has nothing to do with fats in the diet. Lupus is not a diet related anything. Infants with myelomeningocele demonstrate what? Get that big blob on the back and their lumbar area. We know that their nerves, meninges, and their spinal column have pulled up and outside, and you're going to have both motor, sensory impairments as part of it. They're going to need therapy to get as much motion and movement as they possibly can. Myelomeningocele have decreased motor and sensations in lower extremities. The nurse should monitor closely for what? What nerves are down there, right? And it's all about urinary retention. Many of these children, myelomeningocele that have been repaired, will require to be catheterized every 4 to 6 hours. Also, we're monitoring bowel function. Are they constipated? Are they moving their bowels? Because they don't feel it. Their nerves are dead in there. A key feature of Duchenne muscular dystrophy is what happens with Duchenne? is progressive. So you start out, you're working about where you should, and somewhere about 1 year old, they start falling over and waddling, and they're not where they should be. It's because their muscles are progressively getting worse and worse, even with all the therapies, etc. And as I said, it's the heart that just stops in the end and usually causes death in the adolescents. What is one of the procedures that a child with possible Duchenne's may need to diagnose this condition? Duchenne is all about muscles, right? So how are you going to diagnose, are those muscles working? And it's that EMG. Remember, after that test, they have put all of these electrical stimulations in muscles, and it's like they've run a mile. Make sure they're going to hurt. Make sure they have some acetaminophen or ibuprofen, something when they come back from this test. How is Duchenne muscular dystrophy inherited? And it's from mommy, X-linked. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, it's all this nerve gets dead, right? Starts from the feet, ascending upwards. And our concern is the phrenic nerve, again, not working. So it's airway, airway, airway. Very good. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? And it's called ascending. Worse on awakening is your JIA, your joints are stiff. Guillain-Barré is like it all the time. There's no difference. And it starts with you start tripping and falling, and then it gets to that incontinence, constipation, and then it goes to your lungs aren't going to breathe. Their phrenic nerve stops. A multi. Treatment for Guillain-Barré include so Guillain-Barré is usually due to a viral infection that has hit them. It has nothing to do with a bacterial, nothing. So intravenous immunoglobulins boost that immune system. And because it hits that phrenic nerve, they don't breathe, it's respiratory support. Would they get heparin, prevent blood clots? Maybe, but it's that IVIG and respiratory. What type of cerebral palsy causes hypertonicity and poor, fine, or gross motor skills? And it's called spastic. Okay, spastic is what is the one that we think of cerebral palsy, and the one that's that tense and trying to get to you, and they're just so tense. Poor little Jonathan. What priority action should a nurse take to a patient with a suspected spinal cord injury? What's their priority here? My little guy who came in with a fractured neck, it's and mobilize that spine, and making sure you're in control of it. Take control and keep it so that we're not, increasing the injury to the child or adult. You should get a tetanus shot every what years? And it's every 10 years now. Yes, very good. What is a symptom of tetanus? Stepping on that dirty nail, right? And it's that muscle spasms. It's lockjaw. And again, it's respiratory and we worry about it. Very sick with tetanus. And last question. Most common cause of spinal cord injuries are what? It's accidents, motor vehicle, driving, sports. Those are the usual ones we see. Corey, good job, Corey. Number 2, a K. Good job, K. Number 1, DJ. CJ's my grandson. Oh, and big boys in there and KY. So that is this week's stuff. You're going to see some of these questions on your exam. Honestly, they're not so difficult that you're not going to understand them. Remember, are those things that I've said, the concepts of how to take care of broken bones and sprains and what to look for, those things that you'll see anywhere in the adult or in the pediatric population. Remember, I'm here if you need help. If you need help with math, look at your announcements. I've put a brand new math quiz, exam 3 types of questions you'll see. So if you don't know math, do that handout. And it's on your announcement with all the other stuff, the Kahoots, etc. If you don't understand it, please let me know. I'll go over it before we have your exam. I wish you all good luck, guys. See you next week.
Professor Bogart, could I speak with you privately for a moment before you go?
Sure.